At this time, I would like to turn today's program over to Canada Health InfoWay. The floor is yours.
Thank you, Julie, and good afternoon, everyone. This is Fraser Rochford from Canada Health InfoWay, and we're very excited to have this, our first webinar in this series of webinars discussing the findings from our Data Impact Challenge. And so today's test, or today's question that we're concentrating on is, what is the rate of 90-day duplicate lab tests? Julie just reminded you of the call-in number, passcodes, but also please feel free to tweet as we're going through this webinar, and we encourage you to use all forms of social media because I think what you guys have accomplished during this data challenge is worth spreading the word. Today's session is going to be recorded, and so that's going to be available on our challenge website for future use. And as Julie mentioned at the top of this, we are going to be using a Q&A feature, and so you don't have to worry about your name being used. You can hit the up in the top right-hand corner the Q&A button, and then you can type in your questions to the panelists below, and then we will make sure that we address those as we go through the webinar. Today's webinar, we've got sort of a series of things to go through, and so what we want to start off with is, we'll just give you a bit of background. My colleague Simon is going to discuss some summary of findings, and then we have some guests which are going to specifically talk about their own analysis on this question. And finally, we're going to, at the end of it, we're going to have another colleague, Jennifer, moderate a panel discussion amongst you all around what have we learned, what can be shared, and what else around further analysis. So we've got a busy hour coming up, and so stay tuned, and we're going to get started. So Canada Health InfoWay, I think many of you now know who Canada Health InfoWay, and our vision is healthier Canadians through digital health solutions. And with our partners, we help accelerate the development, adoption, and effective use of digital health solutions across Canada. We've been running challenges now for 4 years. We started in 2011, and each challenge is different, and it's sort of pushing the innovation envelope. And certainly we think that the data challenge has explored an innovative way to address some health questions. And by all your analysis, we have some answers to those questions now. We couldn't do any of these challenges without our supporting organizations. They're all listed up here for you to see. In particular, on this challenge, we had the pleasure of working with the Canadian Institute for Health Information, Choosing Wisely Canada, and Casper, who all aided in sort of forming the questions and helping us get to where we are today. So now I'd like to introduce Simon Higgins, our Director of Benefits Realization here at Canada Health InfoWay, and he's going to give you a bit of background specifically on this challenge and some of the results.
Great.
Simon.
Thanks so much, Fraser, and thanks very much, everyone, for joining today. Just as Fraser mentioned earlier, just to recap the purpose of the challenge, we had a couple of nagging questions here that related to some of our evaluation work and some of our activities at InfoWay, and some of our partners had nagging questions as well, which is hard to find the answers to. But we knew that there were folks out there across Canada with data sets that held valuable information and with the skill set and experience to be able to do this kind of analysis. So that was the genesis for this idea of doing a data impact challenge. So what we did was we put some of these questions together and put them out into the field. And so we'll now take a quick look at some of the summary results. 6 questions in total, one of them a multi-part question looking at some of the guidelines from Choosing Wisely Canada. We gave people 64 days. So about 2 months to answer these questions. We put a real incentive on speed. We wanted to get people to try and submit answers as quickly as possible. We were thrilled to get in 41 submissions, which is a really excellent number of submissions, and a really exciting quality, and really some ones that came in quite quickly that demonstrated that there were people out there that were really able to do very quick pieces of analysis and get timely answers to questions. And then importantly, we had 35 judges and really an excellent group of judges that participated in this. And we thank them all very much for their time and effort. And they really bring a lot of credibility and weight to the work we've seen done in the Data Impact Challenge. Folks should know that all of those 41 submissions, all the information about the judges, and a wide variety of other details like the question specifications are all available on the Imagination website. So really do recommend that you go and have a look at some of those. So now turning to our question at hand for the day. This particular one was of real interest to us here at Canada Health InfoWay. We've been involved heavily in lab information systems across the country, making sure that we have digitized the lab results and making sure that those lab results get into the hands of clinicians across the country, and really wanted to understand what's the rate of duplication and how ultimately are digital health solutions affecting that. But right now we really felt there was a need to get a good Canadian baseline because we didn't have a great Canadian baseline to work off of. So that was the basis of this question. So we're basically asking people to go out and look at that rate of 90-day duplication. And the next table that I'll share is a very high-level summary of those findings. So we got 6 submissions for this particular question, and quite a bit of diversity. So really nice to see geographic diversity. So coast-to-coast submissions. Nice to see different kinds of settings where the data came from, and some good recent time frames. So lots of different approaches to the analysis, different data sets. It's hard to compare them all in one table. What we've tried to do here is to summarize the key points and to get a sense of what kind of a range is emerging. And as we move on throughout the discussion and at the end of the session, we'd really like to get a feedback on some of the data that you see here. And of course, all of that detailed data is available in the submissions on the website. So without further ado, we're going to jump into some of the details around a few of the submissions received in this area. We've got 3 teams that have agreed to present today, and we'll be asking each of them to spend 5 minutes sharing a few slides on their findings. So I'll ask the teams to please do try and keep to that 5 minutes. And then we'll have an opportunity where those of you on the line can type in questions and provide questions specifically about those submissions. So anything you're curious about those specific submissions. So you'll have an opportunity at the end of each presentation to provide a couple of those questions. Think of those questions in advance and start typing them in so that we can start those questions right away. And then we'll go through those 3 of those presentations, and then there'll be a good discussion period at the end. So you can save the meaty questions about the bigger picture until the end of the session. So our first presenter, I would like to introduce Bogdan Pinzaru from HQIC. Bogdan, you on the line?
Hello.
Great. Bogdan, I'm going to turn it over to you to take your 5 minutes to share your results.
Okay, thank you very much. First of all, I want to start off with saying that it's a pleasure to present and to contribute to the overall knowledge around statistics and data analytics for healthcare improvement, and especially quality improvement. So I work at Health Quality Innovation Collaborative, or HQIC. We are a non-for-profit organization that provides IT solutions to primary care and generally primary care clinics in terms of data analytics, in terms of a patient portal, in terms of small solutions. And through that technology, we have access to loads of data from different areas, from multiple fits, and we've been able to accumulate that data and be able to provide the analytics that I will present today. So along with me, I've worked with Dr. Sanjeev Goyal, and who is the founder of HQIC, and our analyst and programmer, Deanna. So we'll start off with the analysis. So next slide. In terms of our source, like I've mentioned, we've used the HQIC database. So it included multiple sources data from multiple fits, about 18 to 20 family health teams, family health organizations, and smaller clinics, and out of that we've taken out the low-density lipoprotein specific tests, we've looked at HbA1c, thyroid-stimulating hormone, and hemoglobin. The size of the cohort was 270,000 tests, ranging in 2013 to 2014, 2014 to 2015, and the January 2015 to May when there was the last point that we had available. Next slide. So I think you're all seeing the query itself, and the data was stored in our organization's MySQL database. The query ran to extract all possible tests, and I've worked closely with the programmer to avoid any form of repetition of data, whether if the query were to pull multiple tests within a 90-day period, how it would count it, whether it would count it twice, whether it would count it once. And we've worked through to make sure that we didn't have overestimation of data and underestimation of data. So the 90-day repeat query looked at creating a 90-day expiry date. If a test would fall in that range, it would be included, and it would be excluded, and other forms of that measure would be excluded. Our programmer would have a better understanding of the intricacies of the code and how it was analyzed. And a query was run for each test to be able to pull out the necessary statistics. Next slide. So in terms of the results, so we've had some fluctuation from 2013 to 2014, 2015. And for the 2015 test sample, we had to base our analysis on the assumption that it would double because we only had half of the year at that point. So the statistics marked with an asterisk are pretty much predictions of how that percentage of repeat tests would change over time. And as you can see in the graph, we've had certain, for HbA1c, we've had a certain point where only 2.9% of the tests were repeated, and those were probably due to connection errors or some form of transitioning in the database. So that projection might skew the data a little bit. But overall, we've noticed that the trend is that most results in terms of repeats have decreased, and in terms of looking at the overall of the 4 tests, we've seen a drop from 14.29 to 13 to 11 to a projected 11.53%. The values for just these 4 tests look promising. However, there's still a need for improving the guidelines and to promote primary care to reduce these unnecessary tests for the future to be able to keep this trend going. And like I mentioned before, these family health teams range from Northern Ontario to rural Ontario, and a future analytic would probably look at each of them individually to see how this can be improved. And on our last slide, we have contact information. If you have any questions or any concerns or any of that, we have all our information. Thank you very much. Any questions?
Thanks so much, Bogdan. Really appreciated that summary. We've got a question here relating to some of the decrease that you've seen over the last couple of years, and curious if you've got theories on what's driving that.
So because the company started off in 2013, some of the data was still in its infancy, so cleaning up input that might not provide like an accurate picture of that. But as we've been able to clear up the data from 2014 to 2015, I think that's the most accurate decrease. But however, this has to go over at least another year or so to be able to understand that. And I think it changes in how, in terms of technical changes, it changes in how the clinics have used the EMR and how their understanding of the EMRs have improved. Also, I think from a quality improvement standpoint, the changes in regulations and how our family health teams focus on quality improvement have also played an impact, especially with quality improvement decision support specialists being part of most of these family health teams.
That's great. Thanks, Bogdan. We've got another question in, which is why did you select these particular tests to examine?
We couldn't go over the wide array of tests, and because some of the EMRs had text fields, and the type of test would pop in multiple different facets, I've discussed with Dr. Goyle, and he considered that these were the most predominant tests, and these were the ones at risk of having repeats, and unnecessary repeats specifically. And this is how we've kind of zoned it out. It also, to be able to go through all the tests and to be able to clean up the data, this is a challenge for future analytics, considering we've had a pool of thousands and thousands of different ways to mark test names in the database. So this is again a challenge of current EMRs.
That's great, thank you. And we have one last question for you here. So for the extrapolation in 2015, did you compare the extrapolation to the 2013 and 2014 data to see if that is a reasonable approach? I wonder about the effect of extrapolation from 6 to 12 months.
Yeah, that is a risk that we had to take, because otherwise the data itself wouldn't be as helpful. And it was, from our perspective, it was a reasonable assumption, because as we've seen in January, somewhere in January between summer, we have a high increase of tests, and somewhere in the summer, about halfway through it, we have a decrease in the amount of tests and the amount of patients, and then we see this pattern evolve again. So it is a reasonably fair, but it would be more ideal is at the end of 2015 to pull this data again, run the query again, and see if our assumptions were reasonable.
Great, thanks so much, Bogdan. That was really interesting, and really appreciate you joining us today.
No
so I think we're going to move along to Eric MacArthur now. Eric, you on the line?
Yeah, can you hear me?
We can hear you just fine, Eric. Thanks a lot. So Eric is from the Western Pirates out of London, and Eric, I'll hand it over to you to share your results.
Perfect, thank you. So as you said, we're a group based out of London. We're a satellite working for the Institute for Clinical Evaluative Sciences, or ICES, which is based out of Toronto, and it's a nonprofit organization, and we have access to a wide range of health data within Ontario. So our group specifically, were 6 of us: Ahmed Al-Jaishi, myself, Eric MacArthur, Quan Liu, Doctors Blaine Welk, Michael Orden, and Arsh Jain. So we had a wide range of backgrounds coming together to do this work. 2 statisticians, an epidemiologist, and then 2 nephrologists and a urologist. So if we move on to our analysis plan, one of the data sources we have here at ICES is the OHIP database, which is the Ontario Health Insurance Plan database. So we thought that we could use this to try and pull as many laboratory values as possible in the province during the year of February 2014 to January 2015. So this was the 12 months that are most recent to the current date that we had with our data sources. And as I said, we used the OHIP database, which makes use of physician billing codes. So anytime a physician in the province orders a laboratory test for a patient, they bill this code, and this is how they get reimbursed. And we have all of those billings within our data set, so we can capture all laboratory records very, very well using this for the entire province. So we use these codes to capture all laboratory tests. We didn't specifically look at any test in particular. We wanted to be as inclusive as possible, so we included all tests in the province over this 12-month period. And we defined repeats as any billing for the same laboratory test within 90 days. So we see that within the 12-month period, we had nearly 114 million tests. So you can see it's just a huge amount of tests and people were involved in just this 12-month period. We had nearly 6.7 million unique patients, which is almost half of the province getting a laboratory test done within these 12 months. And we found that 18% of the tests were repeated. So nearly 1 in 5 of the tests were repeated within 90 days. And we see that nearly 2 million of these individuals, or almost 1/3, had a repeat of any kind within 90 days. So it is quite prevalent that these labs are being repeated within 3 months. looking at the most common tests just in terms of counts were a complete blood count, creatinine, and serum glucose, with about 1 in 4 repeating for blood count and creatinine and 15% for glucose. And then based on the physician input, they identified a few tests that they thought shouldn't be repeated within 90 days in most circumstances. And we have these listed here. So TSH, 13%, total cholesterol level, 8%, ABO blood type, 7%. So using our data sources, we can't necessarily ascertain why they were repeated or if they should have been repeated, but they felt confident in saying that these are likely not all appropriate repeats. So things such as blood type, you're seeing 7% repeated, whereas your blood type doesn't change over the course of your life. So unless there was some sort of error in the original measurement, it's something that likely shouldn't be repeated. So those were somewhat surprising results. But I think overall the 18% is probably around what we'd expect. Obviously, with all these different lab tests, some of them are going to be indicated for repeats, and it would make sense. And with our data sources, it's just a limitation that we can't really ascertain whether they were appropriate or not.
Thanks so much, Eric. Really interesting analysis. So we've got a few questions coming in. The first is, if 2 different physicians request the same test for the same person within 90 days, is that counted as a repeat?
Yes, so we didn't look at, it wasn't a repeat for the same physician. It would just be if they had the same test done within 90 days, it's a repeat. So if they had it done and then a different physician ordered it 2 weeks later, that would still be counted as a repeat.
Great, thanks. Another question here. So does the OHIP billing database include hospital-based labs? And if not, what ideas might you have for including them in this kind of analysis?
No, so I think in general, the labs done in hospital come out of the hospital budget, so the physicians aren't billing for that. So you have things like a lot of inpatients who will get daily blood work done in the mornings and that sort of thing, which wouldn't be captured within our OHIP database. So these are largely just outpatient labs, so that's what we focused on. We don't really have a clear-cut way to identify inpatient labs well with the databases we have, which is why we tried to focus on the outpatient setting. Unless you have the specific inpatient values, it's hard to ascertain inpatient labs because they aren't billing for it, so you don't really have a billing record. You would have to just have the specific test record. So that's something we are working on bringing into ISIS, but at this point we don't have it completely available for the entire province.
Thanks so much. That's an excellent answer. Really appreciate that. I think it's something we're very interested in as well, how we can see better access to more comprehensive data sets. Can I ask, do we have Raza Abidi on the line yet? I apologize, folks. We're working to get Raza on the line. He was on the other side of the call, but we hope to have him set up soon. So I'll ask one more question of Eric, and that's about the 90-day cutoff. And do you think that's a reasonable cutoff for looking at duplicate exams?
I think it's hard for me to say. I think someone with a clinical background would likely have a better idea. But I know the physicians were saying for some of these tests that 90 days really isn't that long of a period. So depending on what lab you're looking at specifically, 90 days is probably not going to bring any sort of meaningful change to the value, and in that case it would likely be inappropriate if there was a repeat in that timeline. But there are cases where there's lots of transient, like short episodes of changes. I know coming from a kidney background, there's lots of cases of AKI and that sort of thing where there are large jumps and changes in lab values over a short period. So in those cases, 90 days is maybe quite a long period. So I think it somewhat depends on a lab-by-lab basis depending on what you're interested in.
Great, thank you. And we've got one more question coming in, and it's that it would be significant to know what % of duplicate tests occurred between outpatient and recently admitted patients. Were you able to look at it? Would the data you have available allow you to look at that kind of granularity around duplication?
We could look and see at who was admitted or how many were admitted in that 90 days, but like I said before, if they were admitted and had a lab test done when they got admitted, we likely wouldn't be capturing that as a repeat. So these would likely be outpatient-only repeats that we would be capturing.
Great. Okay. Thanks very much, Eric. Really appreciate your presentation. Some very interesting findings. Raza, do we have you on the line yet? It looks like we're having a challenge getting Raza on the line. So what we'll do is we're going to move along now to the discussion portion of the webinar. So I'm going to turn it over to Fraser at this point in time.
Thank you, Simon. Hopefully we'll get Raza connected shortly, but in the meantime, our facilitator, Jennifer Zelmer, is going to walk us through some questions, and thank you for joining us, Jennifer.
It's my pleasure, and thanks to you all. So it's always interesting to do the summary before some of the detailed presentations, but it's all good as well. Before I dive into some of the specifics, this is our first call where we're looking at the results from the Data Impact Challenge, and we do have a number of other calls of this type scheduled. So in addition to specifics on this call in the Q&A box, would also welcome any feedback you might have in terms of the structure of this webinar, what works for you, what didn't, and any suggestions you might have for future calls. But as you're thinking about that, I want to return us to the overall results. So you saw, as Simon presented earlier, the summary table showing the results from all the teams, and this slide just sort of compacts that again to refresh our memory. If we eliminate the outlier results, so in some cases, teams looked at specific lab tests, as you saw, or looked at very specific patient populations, then the bulk of the results fell between a repeat percentage of 13 and 19% over the 90-day period. And the submission with the broadest scope was proposing found a result of 17.5%. So I think that gives us an interesting idea of the clustering of results that came through. This is reflective across the 6 submissions from 4 different jurisdictions that together accounted for more than 125 million tests. And interesting, just from a challenge perspective, the first of those submissions was received within 2 weeks, and then we also received submissions throughout the challenge period. So if that's the sort of clustering in the center, when we looked at the analysis with more specific scope, that analysis found rates of 6 to 41%. So as you start to look at specific types of tests or specific patient populations, you definitely do start to see some variation across the nature of the results that we're getting. So as you think about that as sort of the summary, we'd be interested in your feedback on this. And Julie, maybe you could push the first poll question. Because this, to us, was an interesting example of being able to get a sense of what the Canadian answer might be to this question by being able to combine results from a series of different analyses on very different parts of the country, very different bases, for the underlying data source, and in some cases different methodologies as well. So on your screen, if you're on the webinar, you should have a question coming up now, and we'd welcome your feedback, and accurate may actually not be quite the right word for this question, but does it seem reasonable to you that, you know, across this basis of analysis that we're finding an answer that clusters between the 13 and 19% range in terms of repeat test results? And one of the reasons that we found this interesting was because this is a piece of information that's feeding now into analysis that we're doing, looking at really the impact of different types of digital solutions that might be used to share lab test results and to look at decision support potentially around lab test ordering. So this kind of information helps to set some of the parameters for understanding the results of that type of work. And Julie, do we have, so Julie, can you close the poll?
The poll is closed.
Great. And then when you're ready, if you can bring up the results. There we go, fair enough. So overall, split vote, I think this counts as. So about half of those responding saying yes, and half, fair enough, saying don't know. And I think that don't know is a really telling answer, because one of the ways that we chose the questions for this data challenge were because the answers were not available from existing sources. So there were literature reviews, there was other information that was looked at in conjunction with our partners before we launched the challenge, and we actually had a longer series of questions, a number of which were scratched off because we were able to find baseline answers. So this was a way for us of being able to understand some information more broadly in terms of these kinds of questions. Also be interested in your thoughts around sharing this type of information. It's obviously a different kind of approach to accessing information from existing data sources and being able to compile that and share it. Talking here not just about the results themselves, but also in terms of the ways that people approach the analysis and some of the lessons learned along the way. I know I've talked to several teams who participated in the challenge, and they were telling me about a number of things that, you know, weren't written in their formal submission, but that were useful things that they learned. So be interested in the Q&A box elsewhere with any thoughts that you might have in terms of what are the kinds of publication vehicles that may be most appropriate. We do know some teams have submitted for formal academic publication. Others are planning on sharing the results with local communities. You heard some of the examples from HQIC and elsewhere in terms of the ongoing work that they do, but also looking at how can we share through vehicles like this, through today's webinar. So if you have any thoughts or suggestions on that front, we would welcome them as well.
Jennifer, I'm going to interrupt you. We actually now have someone from our team, Sam Stewart. You're on the line?
Yeah, can you hear me?
We can. Great.
Excellent.
Okay. The wonders of technology. We're going to just pull up your slides in a second, and Simon, if you want to sort of introduce this team, we can go from there.
Absolutely, Sam. So welcome to the call. So Sam is from the A2I team from Halifax, Nova Scotia, a Dalhousie-based team. Sam, welcome, and please go ahead and share your findings.
So thank you. Sorry for the confusion. I was listening to the webinar, but I was actually third on the list to present, and both Ashraf and Raza had to run off to teach. So I'll be presenting the work we did. We were working with the PATH lab at the QE2, and they handle all the lab orders for what used to be called the Capital District Health Authority is now the Nova Scotia Health Authority Central Zone. But it's the Halifax and area testing. So I'll go right to our results. So this is, we found a number similar to what other people have been presenting in that we have overall around a 20% repeat rate. We thought it was interesting to stratify by type of test. So I presented 9 of them here. I think we had 14 or 15 total. Some interesting findings in that TSH testing and glucose AC were slightly lower. But we were a little more interested in this idea of trying to figure out what was causing repeat testing. And since all we had was lab data, we wanted to look at whether positive or negative testing was the cause. So what we found was that there was a significantly higher repeat test rate after positive tests. It suggests that maybe GPs, especially with tests like urea, would suggest that GPs maybe either don't trust their initial sample or want to confirm positive tests more often than they want to confirm negative tests. So moving further, if you can flip to the next, or do I have control?
We've got your next slide up.
Okay, thank you. So what we were interested in is beyond individual testing is if there was any kind of testing clustering. So we started with just a simple clustering, and this is just counting tests ordered together. And beyond maybe the obvious clustering of cholesterol testing and maybe something with AST and a couple other tests, we didn't find anything right away. But when we moved to a more complex clustering, so this was k-means clustering, and I won't get into the details of the method. I do have control. what we found was that the tests were loosely clustering in kind of 4 groups. And what we identified were order clusters. So we had liver tests, kidney tests, cholesterol tests. These are very loose definitions of these tests. And then we found patients kind of grouped on these clusters. So there are patients that kind of got everything. They got the liver and the kidney panel, those kinds of results, to provide just a little more insight. Now, what we haven't presented here is looking at if these tests were repeating together. The reason we didn't present it here is because they weren't. So we weren't finding any relationship. What we were wondering is if were you more likely to repeat your urea test based on the results of your electrolyte panel? And we couldn't find anything there. We're still looking at it. We might find something later, but certainly nothing to this to report on this case. But the other thing we found, just in terms of test ordering, is that we could actually somewhat predict physician profiles based on the patients they saw. So we've been able to classify physicians strictly from a lab database based on the class of patients they see. Those were our results. We certainly found them interesting, and I'm willing to take any questions if anybody has any.
Thanks so much, Sam. That's really interesting data. So we have one question here, which is, why was the overall proportion of repeated below the positive and negative proportions?
Good insight. So we debated. When you ask yourself what proportion of tests are repeated, the denominator is all possible tests. When you're asking what proportion of tests after a positive result versus tests after a negative result, initial tests drop out of that denominator. So when you're looking at the repeat rate of 20%, one thing you have to ask yourself is do you count initial tests in that repeat rate? A first test can't be a repeat. So the reason those second ones are higher is if we control the slides. Yeah. If we look at this slide, for example, what that gray square in the top right says that of the tests that follow, yes, that one, of the tests that follow, of the tests that were repeated after a positive test, 60% of them were within 90 days.
Great, thanks, Sam. We didn't promise there wouldn't be skill testing questions, so you're doing a great job of nailing some tough ones.
It's a semantic challenge to try and explain it.
So one other question we have is, based on the findings you have, what actions would you recommend for ordering physicians?
So I actually presented this data yesterday to a bunch of med students. Our med students at Dalhousie do a 4-year research project. And I was trying to rope 1 or 2 of them into this project in particular to try and figure out 2 things. And if we're to define it based on this picture, is the height of the squares and the gaps between the squares and the triangles are the 2 things I want to investigate. So especially with the urea test in particular, that seems quite high, 60% after positive versus 20% after negative, or 20, might be 30%. I have no medical knowledge, and I don't know if it's reasonable or unreasonable to repeat, but some sort of prospective or multi-linked analysis through our Health Data Nova Scotia to try and get some insight into why this is the case. And one of the challenges we run into, and I'm sure everyone runs into, this frustrating challenge is we know so little about these patients from lab data. All we know is the postal code of their physician, their gender, and their age. So I would look at linking this to some other data to see if we can get some disease information to see if some of these repeats are reasonable or unreasonable, and if there are disease causes that might be causing some of these repeats or not. That's where I would take this next. In terms of informing practice, I would be reticent to tell doctors to change their practice, but I would tell them these results. And we've been working on another project to provide GPs with individual kind of report cards that just tells them, sorry, not report cards, because that's a grading thing, we're not grading physicians, scorecards or summary cards to give them this exact information. You ordered 600 urea tests last year, 12% of them came back abnormal. You repeated this many within 90 days, just so that they can get their own macro level kind of summary of their lab utilization. Because I don't think GPs are getting that information that often.
That's great. Really, really interesting. Thanks so much, Sam. Really appreciated you working through the challenges and getting on the call to share those findings. I'm going to turn it back over to Fraser now to continue on the discussion.
Great.
Thank you.
So that little interlude hopefully gave more people a chance to think of questions that we want to discuss over the next 20 minutes or so. So Jennifer, if you want to continue sort of leading the charge, that would be great.
Well, we do have a couple that came in the course of the more specific questions. So to share them with everybody so everyone on the call is on the same page. And if you want to hop in on these ideas or on others, you're more than welcome. We did have a suggestion that having reviewed some of the submissions, there were variable efforts to control for either warranted or unwarranted repeat tests. And so judgments need to be made about when retesting is warranted or appropriate. And I think we heard that from a number of people on the call today as well, in terms of the extent to which people were able to look at that question in their analysis. And I think some people, and maybe this goes to Sam, your last point, some people were using lab data specifically and so had a much more narrow set of information that they could look at. And whereas others were using data that had a richer set of clinical information, and so were able to use that in some cases as fodder for their analysis and be able to understand that. But I think it's an important question to say that, you know, not all repeats obviously are inappropriate. How do we start to differentiate those? If you go on to the website, you'll see the reports from some other teams, and there were some teams who specifically looked at different kinds of tests, for instance, and that were more or less likely to be appropriate within the 90-day period. So there were a variety of approaches taken to looking at that. And I think this is maybe a next question up was maybe one that falls from the last presentation, and Sam, I'm not sure if you're still on the line, but it was really looking at how many of the repeat tests really generated a different result. And I think Sam's analysis showed that, you know, you were more likely to have a repeat if your initial test was positive, and I think that begs the question of, well, so did it maintain the same or different? And you could have the same question about a negative result as well.
Yes, sorry, I am here. I had to step out for a second.
Perfect. So I don't know if you guys looked at that, Sam, what the results were of the second round of testing compared to the first?
Just, we had very preliminary results. It was the kind of thing, I think during the announcement of the winners of the challenge, I was looking over what we submitted and just kind of, while I was listening to the webinar, and that idea kind of occurred to me is we didn't look at for repeat tests, was there value in the repetition? And value is always subjective, but certainly at least comparing, you know, if it was positive the first time, was it positive the second? It's something that would be worth looking at. We just haven't, we've only very briefly done it yet and haven't really explored our results at all.
Thanks very much. That's really interesting. So we've had another couple of comments and discussion on this, as well as over the last couple of days, as we're starting to look at some of the value from provincial lab systems. And this is definitely a hot topic for decision makers who are trying to figure out what are the ways that we can actually reduce some of this duplication. So clearly we've got a range. We don't have consensus on whether or not it's a very clear range, but it's clearly above zero and well above zero, into the range that it's a significant dollar figure. So definitely lots of discussion about this topic of how can we address this. And I think, Sam, you had some really good comments that related to addressing it at the clinician level, but we also have discussions from the policymaker level about, from a policy perspective, how might we address this. So we're definitely interested in hearing comments or discussions around that.
And I think the other thing maybe that this reflects back on is the question around, you know, what are some of the factors that influence testing repeats, and also what are some of the factors that might allow us to understand appropriateness versus inappropriateness, because clearly some of those repeats are appropriate, and it's really the inappropriate duplicates that you want to look at and target. And in that context, for any of our presenters who are still on the line, I'm not sure if you looked at this specifically, but this is the kind of follow-up question I think that this type of analysis begs, is to say, so to what extent does the introduction of electronic access to lab test results, whether by clinicians or increasingly, as we're seeing in different parts of the country for patients, to what extent does that affect the level of duplicate results? And I think that's a question that certainly prompted, it was one of the prompts actually for understanding what the baseline was for us, for sure, and that's the kind of thing that we'll be interested in looking at more broadly as well. So I'm not sure there's an answer to that question today unless any of the presenters have looked at that and want to jump in at this point. And I think that's the kind of thing on an ongoing basis that, it's those follow-up questions, right? So it's, okay, so we've now got an understanding in this area, but then what are the next series of questions? And that's maybe, Julie, if you could push the second poll now. Maybe a good segue into our second poll, because we are considering another challenge. It would have slightly different questions and those kind of things, but in considering that, we want to understand the perspective of those like you who've had some degree of involvement in this first data impact challenge. And so you'll see up on your screens there a question about if there was another challenge, would you be interested in participating as a judge, as a team, as a user of the data, or thanks but no thanks? And I believe this is a click all that apply type of question. So because it's a little bit more complicated, I'll give you another couple of seconds to consider your thoughts and options on this front. So Julie, maybe we can close that poll now. And if you could bring up the results when they're ready. This is the moment where all of us who are involved in the challenges are, of course, biting our fingernails to see what the interest level is like. Great. So good mix across. And if you've got any thoughts about, what might influence you to participate or not to participate, we'd welcome you writing them in the Q&As as well. We did do, as some of you know from the first webinar, we had a series of interviews that were done with people who participated and didn't participate, as well as judges, to get their sense about what worked and what didn't in terms of this first foray into this field. And that gave us some really good information about what we might do the same or do differently for future challenges. And so we would welcome any other thoughts and insights you might have on that front. So with that, I think that probably brings us to next steps. And Fraser, it's back to you.
Yeah, so we encourage all of you to share your findings. So certainly we've made them available on the challenge website and through InfoWay, but we encourage you either, whether it be tweeting or using other forms of social media or publishing your findings. We encourage all teams to do so, and also policymakers to take note of these interesting answers. So, publish an article, write a blog post, present your findings at a conference. All of those are things that we encourage you to do. As this was the first in our series of challenge webinars, I want to make note of the next one coming up on October 28th. It'll be another question that we are going to be examining in further detail. Simon, do you know specifically which question that is?
So that's going to be the two questions that relate to inappropriate prescribing in seniors, question 6C and 6D. So it's looking at seniors that have been prescribed antipsychotics or benzodiazepines. And whether or not that's appropriate for the diagnoses they have. And we'll have our friends of Choosing Wisely Canada, Sasha Badia, who will be actually facilitating that discussion.
Great, great. So if that is a topic of interest to you, I encourage you to join and sign up for that webinar. On November 4th, we'll be having a tweet chat. So there's the hashtag, and again, we encourage you to participate with us on that tweet chat. And as Jennifer mentioned, we are thinking about another data challenge. So we will be back. Stay tuned, and we encourage you to watch all of our communications from InfoWave. So I'd like to thank each of the teams that participated in today's call. So all three of you, you did a great job. Sorry for any technical difficulties there, but we thank you for your participation. Simon, great job. Jennifer, thank you for moderating, and we look forward to speaking with you all at the next webinar. Have a good afternoon.
Thank you again for joining us today. This concludes today's web conference. You may now disconnect.